high-risk individuals, reactogenic vaccines can precipitate thromboinflammation. And ultimately, yesterday, the statement was issued that benefits versus the risk, and this says the benefits are more than the risk. That means the whole world has accepted that there is a risk. So when you say risk, benefit is more than the risk, it clearly tells you it becomes a prescription drug. And when it becomes a prescription drug, you will have to weigh its side effects like you weigh in any other drug. Now remember that the vaccines available to all our countries can be a single drug vaccine or a fixed dose combination drug. The vector vaccines are a FDC. So the Oxford vaccine and the Covishield are a FDC because two viruses are involved to make into one vaccine. The Chinese and the Indian inactivated vaccine is a single drug vaccine because there is only one virus involved. Unless you want to add it as, because adjuvant is also added, you can also call it as a fixed dose combination vaccines. And we have last time discussed, I want to revise what we discussed, then I'll show you some of my experiences in side effects, which will clarify what we discussed last time. And after that, I would like to listen to Dr. Pillai, then Dr. Chaudhary, Ravi, and others who join. Their country anecdotal examples of side effects of the vaccine. So I said last time, when the virus enters my body, the body will treat it as a foreign body and may initiate a Th2 response, which is an allergic response. And the allergic response can be type 1 IgE mediated immediate anaphylaxis. A person can die if not given adrenaline in time. Or it can be 6 to 8 hours non-IgE mediated, complement mediated response. The patient may develop allergy after 6 hours. It can be suppressed by montelukast, cetirizine, ranitidine or famotidine, and aspirin as per a standard non-IgE mediated protocol. Some people will develop type 4 skin reaction, which is like a lepromin test or a tuberculin test. So when you do a tuberculin test, you develop a rash appearing after a few days, third day, fourth day, 72 hours response. On the arm where you have given the vaccine, you may develop a indurated, raised, inflammatory skin lesion appearing after third day. Some people may develop type 3 response, which is Arthur's reaction, which will be a skin joint kidney involvement. Some people may say that after the vaccine, I am getting involvement in my joints or hematuria or in the kidney. These are allergic reactions. After that, if the allergic reaction does not happen, the new vaccine enters my body. When the new vaccine enters my body, it will try to enter my cell through endocytosis. The normal virus will enter through a ACE receptor or a transmembrane receptor, but a virus vaccine will enter by endocytosis. So at the surface, it will be stopped by the toll-like receptor, and inside the cell, it will be attacked by the knot-like receptor, and they will try to kill the virus protein. That means the adenovirus or the coronavirus protein. If that protein enters the nucleus, makes a mRNA, and start producing spike proteins inside my cell, my cell, two things will happen to the cell. Outside the cell, cytotoxic cells will accumulate to kill that cell, and they will direct the B cells to start producing antibodies. And inside the cell may explode as a suicidal bomber called as pyroptosis. So whether it is a virus or whether it is a COVID vaccine, the response will be the same. But in a COVID vaccine, you will have a limited response because the virus is non-replicative and the gene is non-replicative and the protein is non-replicative. Therefore, you can get a systemic inflammation, but that inflammation will be stable and under control. So therefore, we do expect after the vaccine some degree of reactogenicity, which means some patients' underlying immunity may get exacerbated. Some people will show distinct inflammatory response as seen in coronavirus, but there that is seen for days together. Here it will be seen only for 4 days. Here it will be seen only for 4 days. So I'll start showing you some of the slides which will explain everything what I am doing. This lady, medical doctor, she was given the vaccine. She came back home. She developed severe myalgia, which is gamma interferon response. For her severe myalgia, the husband gave her IV diclofenac and she died. So the question comes is, did she die of the delayed anaphylaxis of the vaccine, or she died of anaphylaxis to diclofenac, or she died because of both the vaccines given together in an interval of 1 hour? So we have two more anecdotal examples. One more anecdotal example, 95-year-old female in Toronto received 2 vaccines on the same day, and she is still fighting for life. Here also the patient receives 2 vaccines in a matter of 2 injections in a matter of few hours. The patient died. My interpretation is both the vaccine contained polysorbate 80, because the injection diclofenac also contains polysorbate 80. The Covishield also contains polysorbate 80. It was a polysorbate anaphylaxis occurring in this particular female. So therefore, the CMAAO recommends, after you have been given a vaccine, for the next 2 weeks, at least for the next few days, do not take any other injection which may contain polysorbate 80 or polyethylene glycol. That's my recommendation based on this example. Now we have 2 more anecdotal cases. 65-year-old person collapsed within minutes of receiving the first dose of COVID-19 and passed away 1.5 hours later in ICU. Anaphylaxis, classical anaphylaxis. Another 45-year-old man died shortly after he was administered the second dose of COVID-19 vaccine. And we always say anaphylaxis is more common in the second dose than in the first dose. So these are the three examples which I have shown. So therefore, anaphylaxis can come to anybody. And anaphylaxis, if not treated in time, unfortunately, we don't have an EpiPen in India. Therefore, I always say keep the adrenaline injection ready whenever you are giving a vaccination. Now, these are IgE mediated anaphylaxis. Now, these are non-IgE mediated anaphylaxis. Non-IgE mediated anaphylaxis. Female, 6 hours after the vaccine, developed angioneurotic edema. This is classical non-IgE mediated anaphylaxis occurring between 6 hours and 24 hours. She was on 5 milligram prednisolone. She's a liver transplant patient. And if she was not on prednisolone, this reaction would have been severe. If this appears within 15 minutes, you can say this is impending anaphylaxis, but she developed it after 6 hours. This is complement-mediated allergic reaction. 24 hours later, this female developed a rash on the neck. Again, non-IgE mediated, complement-mediated allergic reactions. These are the allergic reactions which you can prevent by pre-medicating them with Montelukast H1 and H2 blocker. This is urticaria developing on day 2. Again, non-inflammatory, allergic, complement mediated. Again, if this urticaria develops within 15 minutes, then it is IgE. If it is developing after 6 hours, this is non-IgE mediated. You can see another patient, 31-year-old with urticaria. Now, I'm now going to show type 4 hypersensitivity reaction, which is extremely common, and you may confuse it as a local cellulitis, abscess. I'll show you, this is a patient. This will occur after 2 to 3 days. It will not happen on the first day. It is like a lepromin or a tuberculin test. All these patients will develop a local reaction starting at 72 hours. We will be tempted to give him, this is a staph abscess, patient was not given properly. No, this is typical cell-mediated immunological reaction occurring on 3rd or 4th day. This is what it will happen. This is what a orthopedic surgeon who developed it after 3 days, local reactions. These reactions can be at the injection site, but can also be on the same hand or remotely from the injection site. So these are type 4 cellular responses. These are another type 4 cellular response on the shoulder. This is another type 4 cellular response on the shoulder. This is what I have taken from the literature, which shows clearly how big the type 4 response can be, because they have a fair skin. So on a fair skin, it looks like that. And this is again taken from New England Journal of Medicine, which shows if you have a type 1 response on the first injection, you may not have it on the second injection. You can see different types of type 4 reactions. Now we come back to, can vaccine precipitate underlying allergy or underlying inflammation? Let us see anecdotal examples. This is a patient which is in Lancet, which showed after the vaccine, patient unfolded her underlying rheumatoid arthritis. And we saw a similar case here in an elderly female where her underlying rheumatoid arthritis worsened. Here it got precipitated. So it's possible. This is another case where we saw a dye allergy, that she had an allergic to dye. When she was given a vaccine, her eczema got precipitated. Her eczema on the ear got precipitated. You can see a drop of the plasma coming up. I have 2 patients whose herpes zoster got precipitated. 2 cases of Bell's palsy are being told to me, one by the Singapore and one by the Hong Kong. that their Bell's palsy got precipitated. I have two patients of herpes zoster got precipitated after the vaccine. So this can happen. Theoretically, it can happen. Now, talking about inflammation, can vaccine precipitate inflammation in the body? So I have a patient which I'm still writing. He had a anal sinus got exacerbated, but this is a young 30-year-old lady who developed severe lymphadenitis. You can see the inflamed vein over it in the chin region starting on third to fourth day. This is a lady who is a 76-year-old female who developed episcleritis. I have a medical prescription. I don't have the picture. So this is a proof that she developed episcleritis developing sixth and seventh day. This is a patient who developed left eye conjunctivitis after the vaccine, the same way we used to see them in COVID. Can we develop some degree of thrombosis? Yes. We have 60 cases of death in India. I'm only taking one example. He is a police ACP, Assistant Commissioner of Police, who was having severe OSA with sleep apnea. And after the second dose, he developed heart attack and he died. 60 such examples are available in India where they all developed arterial thrombosis because of precipitation of inflammation. This is another patient who developed after 1 week. He developed, you can see here, a thrombocytopenic rash. His platelet starts dropping. It became 150,000 from original 400,000. So this is a patient who developed his D dimer rose to 500, and he developed a skin rash after 1 week of the vaccination. I call them as thrombocytopenic purpura, TTP, where you see bleeding, clot, and low platelets together. So this is a classical example of TTP. Post-COVID, post-vaccine systemic inflammation. So I'm talking about post-COVID, post-vaccine. All those patients who have developed COVID, and if you give them the first dose of vaccine, some of them are showing fever of more than 101 and sudden rise in CRP of 40, 50, and 60. So these are the cases. A lady, day 1 CRP was 4.2, D dimer was 0.2. After vaccine, on day 40, D dimer rose to 1.02, obese, hypertension, past history of COVID in May. Another person who is, I'm still awaiting his reports. This is another patient, vaccine, same day, her fever became 102 and CRP D dimer rose. This is another patient which also has the same phenomena. This is the latest portion. I got it in the morning. This is developing a rash in the legs. You can see it after 1 month. We don't know. So I'm putting it at anecdotal examples. I'm not being able to figure out how can he develop a rash after 1 month. But yes, he is developing redness and rash. That means he is now coming back and saying, I have developed this today. Tomorrow is my date for second vaccine. Should I go for not? That's his question. Should I go for the second vaccination or not? Therefore, he have come back to us for this particular thing. This is another patient who has varicose venous ulcers. He has varicose and venous ulcers. He developed a rash in his leg in the calf muscle area, and he is not on aspirin, so I can't call it as a ecchymatosis. This is fourth day. So after the vaccine, over the area where there are multiple rashes, he developed an extra rash. So my initial reaction was this might have happened because of aspirin or any other drug, but he denies. So these are anecdotal examples. Therefore, the virus vaccine can convert normal to pro-inflammatory status to inflammatory, pro-inflammatory to inflammatory and thrombotic, and pro-thrombotic to thrombotic state. So idea is to share anecdotal examples, what can happen after the vaccine with a logic that this vaccine contains the same protein as the protein is present in the virus. It contains the same spike protein gene as present in the original virus gene. Therefore, this company has no choice. They will have to give you the same protein and the same gene of the original virus. And if the original virus is thrombogenic and inflammatory, this has to be thrombogenic and inflammatory. But in an original virus, the virus is replicative. So therefore, immunogenicity will last longer. Here it is a single shot. Therefore, you can get transient manifestations. So therefore, last time when we said that in susceptible high-risk individuals, reactogenic COVID-19 vaccines can precipitate thromboinflammation. The only thing gets added is the vaccine being a drug, which can be a FDC fixed dose combination drug or a single drug, being a drug can also cause type 1, type 3, and type 4 allergies like any other drug. And therefore, I justify the decision of the European regulators to allow use of all the vaccines with a warning that benefits outweigh the risk. So they have not said the risk is zero. Therefore, it becomes our duty to evaluate every high-risk susceptible individual, what is the risk and how to prevent. Over to Dr. Yes, Dr. Ashraf. Dr. Ashraf, are you there?
Thank you very much, KK. If everybody can listen me, now I hope we can open the session. Anybody who wants to comment or
I would like to listen to everybody if they have some experience of side effects in their countries.
Yeah.
And after Professor Ashraf hands over, then Dr. Chong will summarize. Yes.
Yeah, thank you. So house is open for discussion. Anybody can.
Dr. Jamal, do you have any country? Yes, Dr. Chong wants to talk about.
Morning, President. Morning, Professor Sharaf. I just wanted to update. I saw my staff again yesterday. Her facial palsy her Bell's palsy is getting better. She's recovering, and we floated the case up to our ex-director of medical services, who's also involved in the pandemic response, and he's also a neurologist by training. So he's asked her to defer the vaccine for another 2 weeks, and to carry on after that. So just to update everyone on that facial palsy. I had a patient who was in London and she received her first shot of AstraZeneca vaccine. And I think she's a bit worried, a bit anxious, and she has tingling everywhere, but I think it's probably supratentorial. But nevertheless, she went to see a GP and she was convinced she had the beginning of transverse myelitis, which I doubt so. But there's a lot of worry in London because of the AZ vaccine. A lot of worry because of the bad press and the fact that several countries, halted the vaccination process. And the vaccine hesitancy in the UK is quite bad because the people are not convinced that the European regulator has okayed it, but Brexit and all that, so they are a little bit concerned about the situation. Thank you.
Why I'll ask a question is, why shouldn't transverse myelitis come? It will come in susceptible individuals. It has to come in susceptible individuals. And I would say that all immunological reactions, and then the second question comes is just ask yourself, male or female. If it is a female, it is pakka, it is 100% transverse myelitis, because out of 67 anaphylaxis which have occurred, majority have been the women. Women have more Th21 response than Th1 response. So if you see your Bell's palsy female, transverse myelitis plus minus female. Hong Kong, what was the Bell's palsy?
Yes, good afternoon, Mr.
Male or female?
President.
Male or female?
The Bell's palsy patient in Hong Kong is also a female patient,
That's
I
also a
remember.
female. So that confirms women have more allergic reactions than men. So if a woman says some symptoms, don't ignore it. Don't ignore it.
Well, the ratio of female
I
to male,
believe
they
even
said
if a
should be
female
about-
says, one should not ignore.
But that is always.
Yeah.
So clinically, if women complain of
Right.
symptoms, I think we have to pay
Right.
attention a bit more closer.
Yes.
I think that's the lesson learned, President. Thank you.
Yeah, Dr. Chong. Dr.
Yes.
Chong,
Yes.
Yeah. I just want to respond to the unfortunate what happened to your patient in UK, and the people had worried about political influence on the decision in using or not the AstraZeneca Oxford because of the Brexit matter. Well, in fact, I have friends in Norway, and so they also had, in fact, the Scandinavian countries, the four, had continued to halt the use of AstraZeneca Oxford, but they do not belong to EU. Whereas the EU had resumed using AstraZeneca, perhaps you said because of political pressure, they need the vaccination. In fact, they need it badly. So the EU had already resumed it. But however, it's the Scandinavian countries which continue to halt suspend the vaccination with AstraZeneca, and they do not belong to EU. So perhaps it demonstrated rather to the rest of the world that it is the Scandinavian countries that are true to scientific consideration, whereas the EU had already succumbed to the political need to go on for mass vaccination. So even with these clotting problems, they would continue to use it. But I really think that is not really a big deal. We already, well, with the enlightenment of our president, knew this a few weeks ago, that I mean, the immune response of the vaccine will by itself inherently have this consequence. So in fact, of course, we have to have the precaution whether the preliminary medication, will it be useful? Now, because aspirin would help the thromboembolic events, all right, beforehand. But what can we do to have the precautionary prophylaxis for this clotting or thrombopenic outcome? So what can we help the patients if they really want to have precautionary medication?
So I want to suggest that all those patients who needed an anticoagulation while they had COVID, if they go for a vaccination, they will also be put on anticoagulation. That's one. That means somebody said I was put on rivaroxaban or dabigatran, they should continue that during vaccination also. Number two, all those people who would be put on anticoagulation if they are undergoing any surgery, they should also be, because this is like any patient who is procoagulative, and if you give a vaccine, may be put on anticoagulation. In a lower risk people, you may prefer aspirin, but in a high risk people, you may like to give them even anticoagulation before the vaccination. These type of female who are likely to get post-vaccine So this lady, Dr. Chong, who developed Bell's palsy, did she had a COVID in the past?
No, President,
Sure.
she did not.
She did not, and she doesn't have COVID antibodies.
No, she does not.
She does not have, because we are getting a lots of cases. If you develop COVID and now you develop a vaccine, then systemic inflammation is common. Colchicine would have prevented these inflammations. So in a high risk individual, colchicine would prevent these inflammations, because these inflammations are hyperinflammations. So I again want to revise three types of inflammation in the body. One is called as a free radical inflammation in my body, which is presence of oxidation. You have a reactive species of oxygen or nitrogen, which are causing mitochondrial stress and causing inflammation. The second is pyrogen induced inflammation, as in this case, which can be the virus or the protein. So there will be two types of inflammation, inside the cell and outside the cell. Inside the cell will be NLRP and response, which will be interleukin 1 beta response. So remember, inside the cell, when there is an inflammation, predominant interleukin will be IL-1 beta and IL-18. Outside the cell, when other cells attack, they will attack using IL-6, tissue necrosis factor, and gamma interferon. So there will be an attack on the infected cell from inside and the outside. Outside attack, we don't want to suppress, because outside attack is also giving you an opportunity to call B cells to produce IgG and IgM. So therefore, we don't want to give steroid to suppress, which suppresses Th1 response. Therefore, we don't want to give them infliximab and adalimumab, which are all suppression of TNF blocker. But if you suppress the inner cell response and prevent pyroptosis or hyperinflammation by mefenamic acid or colchicine, you are not going to hamper the immunity, but prevent hyperinflammation induced systemic inflammation. That's my take on to that.
Excellent summary, President. Very, very good summary.
Dr. Chanda Pillai.
Good morning, KK. Your illustration regarding complications and adverse reactions has been very nice and very impressive and very evidence-based. And Indian scenario, you know, we are more or less going into a second phase. And since January, the number of cases has been increasing. And yesterday we had the maximum number of cases that we ever had on a single day. So that is the scenario. Regarding vaccination and the adverse side effects, India, we have vaccinated almost 4 crores of people with Covishield and Covaxin. That is, if you look at the side effects, compared to the benefit, it is much less, and the incidence of thrombosis and even hemorrhage and other complications has not been more than normally that you expect over a period of time. So the health minister has declared in the parliament itself that we will continue with our vaccination program, and it is safe, and compared to the benefit, the side effects are negligible. But then, as you already mentioned, the susceptible population, particularly post-COVID and others with comorbidities, the chances of adverse reactions are much more. And whether it is, it's only a random thought, whether it is worthwhile to do ferritin D-dimer, HDL, and CRP on these sort of selected patients with the comorbidities or post-COVID, and whether that will give us a clue to the prophylaxis, whether steroids are to be given or anticoagulants are to be given, whether that will be useful or in a mass scale of vaccination, whether these sort of steps are practicable. And some hints you have already, and you have always been giving on use of colchicine, aspirin, and other things where normally investigations are not required. But for these major complications like hemorrhage or thrombosis, whether these 4 parameters in selective cases, whether they had to be done, and on the basis of that, anticoagulants or steroids are to be given. So it's a wild thought.
So I want to add, with the permission of the chair, post-vaccine, we are getting, remember, a combination of a triad. The triad is clotting, bleeding, and low platelets. Remember, D-dimer is a costly test which tells you about clotting, and the indirect marker is low platelet. So we are now believing if the CRP is rising and if the platelet count is falling, not fallen. A falling platelet and a rising CRP means you are developing a combination of called clotting, bleeding, and low platelet. Up till now, we were taught 3 reasons for that. That is TTP, thrombocytopenic purpura. I'll show you one example. Second used to be DIC, and third used to be hemolytic uremic syndrome. These were the 3 reasons. Now I have added the 4th one, post-vaccine, post-COVID vaccine in susceptible individuals. You can see this triad of thrombosis, that means high fibrinogen, bleeding, clinically evident bleeding or clot retraction test, low platelets, high D-dimer. So if you get high fibrinogen with high D-dimer, it is this combination. And now in population where D-dimer may not be so cost effective, if you find a patient with rising CRP and falling platelet count, look for this complication.
Res, can I just ask a question? I remember you were saying just now when you were talking about the pyrogen response inside and outside the cell. IL-6 is the one that triggers a CRP, I remember, right? Is that what you said?
Yes.
And gamma interferon triggers myalgia.
Yes. Gamma interferon is the first response. It's like a chowkidar. It's like a security. It is a signal introducer as well as killer. It will cause the initial response of myalgia, pain, fatigue, fever, mild grade fever is all gamma interferon. And if the gamma interferon is not produced, then Th1 response comes. So Th1 response is a standby to gamma interferon. So when the protein enters, gamma interferon will give you a local illness and nothing may happen. But if gamma interferon is delayed, production of gamma interferon is delayed, then Th1 takes over. It produces locally TNF blocker, attracts the neutrophils with interleukin 8, produces interleukin 6. Interleukin 6 is a systemic signal communication. It communicates to the whole body that something has happened in my body. And in the meantime, if they are not been able to take, then the cell will prepare itself to commit a suicide called pyroptosis through IL-1 beta. That is called NLR response. So these are in sequence. If gamma interferon cannot take over, then IL-6 takes over. If IL-6 is not been able to handle, that Th1 response is not been able to handle, the cell will prepare itself to commit suicide by a process called pyroptosis through a nuclear factor kappa B pathway and using the NLR NOD-like receptor pathway. That's the sequence.
I see. So let me summarize again. Gamma interferon is the initiator. If it fails, if it delayed or failed, then TNF takes over, IL-6 comes in.
Response. This is called Th1 response, tissue helper 1 response.
Yes.
TH2 response is the allergic response. TH1 response is the inflammatory response.
And IL-6 takes over, and then subsequently, if all fails, then the pyroptosis occurs with the NLRP's pathway.
And that
That-
pyroptosis is called as a suicidal bomb.
Yes.
That is called a abnormal apoptosis, and that is called as a storm. That is becomes a storm, depending upon the where the storm comes. So we are getting this storm called as a mini extrapulmonary inflammatory responses after vaccine we are getting, because there is no lung involvement, other systemic involvement is coming. Patient presenting as the differentiating feature is that gamma interferon will never cause a fever of more than 100.4. If the fever is more than 101, this is pyroptosis.
Excellent. More than 101. Excellent. So it's quite interesting because, President, what you've said to us, what you've been telling us is actually a combination of armchair immunology relating to clinical signs and symptoms, which is very fascinating, isn't it?
Yes. And this is what we are learning. Every time we are learning and making ourselves more clearer.
Yes.
Yeah.
So the combination of understanding the immunology coupled with what we can test in the blood, coupled with what we can see in the patients clinically. Excellent.
And that has to be cost-effective test. So it can't be a test which are affordable at any level. So therefore, I brought the concept of falling platelet and rising CRP, which are the cheapest tests available anywhere in the world.
Yes. Does it have to be highly sensitive CRP, President?
Yes, it has to be high sensitivity because you require number of 0.3. Any variation of more than 0.3 is important. That will not come without high sensitivity.
Thank you, President. Very illuminating. Puts everything together. Excellent.
Anybody else who's there?
Yeah,
Mr. President, sorry, Mr. President, I beg your pardon. I have to correct myself. Just now, I told you that the Bell's palsy patient in Hong Kong is a female. Sorry,
Really?
I had checked it, fact checked. It's male. It's a 69-year-old male. But the interesting thing is that the Bell's palsy developed within hours of the vaccination of a killed virus, the Sinovac. So in fact, people are still doubting whether this Bell's palsy was really due to the vaccination because it occurred just within hours. Would it be too early? And well, but of course, still, even though it's a male, it doesn't mean anything. It's a majority is female. That's all. Not everybody must be male.
What
Of
we
course.
are saying is these are triggers. We are not saying the cause effect. There is a difference between causation and a trigger. So if something is oncoming, it will trigger. So we are
Yes.
talking about is that the vaccine can trigger immunological reactions. So we are not causing anywhere. So the government is also correct. It is not causing it.
Yes.
Okay, but we are not talking. It cannot cause. It can only trigger.
Yes.
That's right. Yeah.
Yes, exactly. In my patient with the facial palsy, it occurred 1 week after the first injection, after the first vaccine dose. And rightly so, as what President has said, our ex-director of medical services, who's a neurologist, said that it's not a causative factor, but of course, it could well be a trigger, as what President has said. Thank you.
What is the age of that lady?
She's 39. Her only risk factor is that she's obese. She's otherwise quite healthy.
You can't be contradicted to each other. She's obese and healthy.
I mean,
Otherwise.
sorry. Otherwise, I correct myself. I stand corrected. Her CRP is actually normal. We did a blood test for our staff routinely every year. Her last blood test, her CRP was normal.
Normal means what? There has to be a number.
Less than 1. Highly sensitive CRP.
Okay,
Less than 1
that's good.
milligram.
Mr. President, so what about ESR and procalcitonin? say just now you said the high sensitive CRP would be a very useful indicator. Comparatively, what about ESR and procalcitonin? But of course, procalcitonin is too expensive in itself.
So there are only few studies which talks about high procalcitonin, that too only in patients who are on ventilators. Whether actually it is viral in origin or mycoplasma in origin, we don't know. Regarding ESR will start rising late and will come back to normal very late. So therefore, ESR is only a factor to tell you whether the inflammation is over or not. CRP is the one which tells you about acuteness. So acute inflammation, therefore, is acute phase reactants will be more important for CRP as far as COVID is concerned. ESR may take 3 months to come back to normal.
President, I remember you mentioning the mechanism for ESR is there's some, what is the trigger for the ESR? I remember you mentioned it a while ago.
Fibrinogen.
Fibrinogen?
Yes. Fibrinogen will increase the ESR and the debris. The kill debris.
Okay. What about
PLA2, PL phospholipase A2 induced debris will increase the ESR.
Yes. You also mentioned something about the free radical and the oxygen free
what
radical.
happens in the body is there is a mechanism of injury in the cell without a pyrogen. Okay.
Okay.
So
is there any role for this in our COVID vaccine patients? Is there any role for free radical damage?
So what happens is that the response to the classical free radical is a pollution PM 1.0. So when you have the pollutions coming in, insecticide, pesticide, all come in, they produce free radicals in the body. Now, free radical is a atom or an element with a minus O without neutralization. That becomes so this produces reactive oxygen species. This causes oxidation in my body. So for example, if I take a lipid, it will cause lipid peroxidation. It will become an oxidized lipid. So in my body, I get oxidation of my substances in the body, and that oxidized substances will produce an inner mitochondrial stress to produce high CRP, and that's what we call them as a that is what we call them as a free radical induced injury. That free radical induced injury can also happen because of anoxia, can also happen because of like anoxia, hypoxia, which is developing, and the pollution. So now they are saying is whether somebody now will have to tell us that in polluted countries, is the response of vaccination different? That time will tell us. As they said that COVID-19 is showing more problems in vaccinated areas, in polluted areas. Maybe we may come back and correlate the amount of antibody protection vis-a-vis the pollution levels in the air.
Thank you, President, for your kind analysis, and obviously a lot of hard work has gone into it. Thank you very much.
Japan.
Can we listen to Chaudhary? Jamal is waiting, I mean.
Thank you.
Yeah.
Thank you very much. Dr. K. Agarwal, thank you so much for your nicely orchestrated this presentation. And actually, you asked about the expenses due to vaccination here in Bangladesh. Actually, we are not informed much, but we have seen, and discussion is going on regarding the death of two eminent personalities just 1 or 2 days after the vaccination. So that may be anecdotal, of course, which we are seeing throughout the world. They were 75 plus, 80 plus trade, and so I'm not sure whether it is due to vaccination or not. Second thing I want to ask, actually, Dr. K. Agarwal, you were just mentioning that you didn't develop the antibodies after 25 days or something like that, even after 3 weeks of the vaccination. So you are advised to take the vaccination second dose before the scheduled date. So there is saying is that even the DPT after one dose, the antibody doesn't develop earlier. So you need second or third after third dose. This may develop better. So I don't know what is the answer behind it. I have seen yesterday or before yesterday somebody was telling he also got tested for antibody and he hasn't seen any antibody here, even after 1.5 months. So I don't know what is the answer behind it. So what I feel that I must say that because the benefit risk ratio is much higher, so we must encourage the people to get for the vaccination. And as a physician, and of course as an organization, we can just suggest and come to a point that we may take some sort of pre-medications or some sort of measures which will prevent this sort of bad incidences here after vaccination. Thank you so much.
I agree, Jamal. So I only want to say is that I have Crohn's disease. I did not develop antibodies after the first shot. 2 weeks after the second shot, I got my antibodies done at 2 places. One place they said 0. The second place they said very mild elevation. So either I did not develop, if I developed it very mild elevation of antibodies. Now come back to other RNA vaccines. Let's talk about rabies vaccines. Initially, we used to give them 14 injections, then 5, now 3. So I'm particularly very clear because in RNA viruses, in susceptible autoimmune disorders, you may require multiple doses. Remember in hepatitis, in CKD, we give double the dose of hepatitis vaccine.
Yes.
We never give a single dose of hepatitis vaccine. So I'm of the firm opinion, people like me who have Crohn's, I'm still following myself, may require an additional dose of vaccine. So it has to be decided on a case-to-case basis. And people who are on strong immunosuppression and not immunomodulation may require multiple doses. Now, what is the risk? If I develop, either I don't take the vaccine, I'm okay. But if I take the vaccine, I must develop the antibodies. If my antibodies are inadequate in my body, and if I actually developed a corona, it may enhance the disease. So inadequate antibodies may be more harmful than not getting them. So therefore, all those people who have inadequate antibodies, I'm 100% sure on record that 3 months from now, the whole world will start talking about that a third dose is required in people with immunosuppression, or a double dose is required in immunosuppression. And I'm also of the firm opinion that delaying the delaying the 28 days protocol in immunosuppression is not advisable, because in a immunosuppressed people, if you delay the second dose, it may harm the person if he actually gets a COVID-19 infection. That's my personal observation. And I'm the classical example. I don't have an option of taking a third dose. Otherwise, I would have experimented myself and given the third dose.
President, it is already, I think, the third dose. People now talk about that the third dose is essential if you have not developed antibodies.
I know, but my protocol in India doesn't allow it at the moment.
That is different. That's the difference.
So otherwise, you will have to invite me and I come there and you give me the third dose.
We are on a very low size in Pakistan.
But with the third dose, be really prone to develop more anaphylaxis towards PEG.
Absolutely.
That's
Absolutely.
in the
Second, yes, every time you take a new dose, if you are allergic, it may produce more anaphylaxis. So accordingly, get prepared for that. So the lesson today is that it's a prescription drug. Vaccine is like any other ordinary prescription drug. weigh benefit versus the risk, take appropriate precautions, and give them. Even the aspirin is not safe. In susceptible individual, it can cause GI bleed, but you still give it. You still give aspirin in patients who are at high risk under observation. So give it under observation and take care of it with the proper consent. So I
Professor,
like now
Very true.
Professor Ashraf to have Mary lastly to speak, and then if Dr. Sajjad want to add something, then you summarize, and then Dr. Chong closes the meeting with his summary.
Thank you very much. I think it is very elaborated meeting, and certainly the time when people are talking about the complications rather than the risk. And it has been made very clear by our President Agarwal that the risks are less than the benefits. So we should promote as the leaders of the associations to encourage people to go for the vaccination. As far as the side effects, as we have come to know, that it is not the reaction or side effects of the vaccine itself, but it triggers. I have learned that immediate anaphylaxis, as any vaccine or any drug can produce, that is over there, but precautionary measures has to be taken. I appreciate that the allergy level, that is after 6 hours, typhoid skin rashes after 72 hours, and underarm skin that is there, and about the joints and hematuria allergic reactions, that is also one of the reactions that we have to speak about and inform to the clientele which come for the vaccination. If shortly that all approved vaccines, including all what are available in the world, these can be used and very high efficacy against severe COVID. High to moderate efficacy, that is 60% to 95% against symptomatic COVID, but poor efficacy only against asymptomatic COVID. I believe people should not run after efficacy data while choosing a vaccine. Because of all vaccines prevent severe COVID and death, vaccination of large cohort of population is important if we want to save the humanity from ill effects of the current pandemic. Everyone should get vaccinated and encourage others to get vaccinated. I think, thank you very much, Agarwal, Mr. President, for your all continuous efforts to enlighten and to give the awareness amongst the CMAAO countries. Thank you very much. For me, it's over.
Professor Ashraf.
Yeah.
Hi. Good morning. So,
Good morning.
how is the situation in Pakistan? You are vaccinating with Sinopharm, is that right? And what else? How's the progress? Are there any side effects emerging?
In Pakistan, Sinopharm, one very unfortunately that Pakistan is on a very low number in vaccination programs. We are just have about 500 million or so on vaccinated people in Pakistan. But luckily, there are no reactions or the side effects of the vaccine, which we are using the Chinese Sinopharm. What all Mr. President Agarwal talked about. Luckily, in Pakistan, there is not a single reported side effect of the vaccine.
See, most of the side effects in India also are coming of Covishield
Dr. Ashraf,
vaccine, and that is probably because it's a FDC, fixed dose combination.
Dr. Ashraf, the information is it coveted or is it okay?
Pardon?
The information regarding the adverse effects, is it somehow coveted or is open?
It is open. It is open. It is open. Now it is the government, and we have a very strict control, frankly, over here in Pakistan, as far as the vaccination program is concerned. And follow-ups are there. I have been the pioneer one of the projects in Pakistan, and I myself know about it, that the follow-ups are on a very standards and good standards and controlled standards.
Mari, you want to speak? Mari, Ravi from Malaysia.
Yes.
Hello?
Yes,
Oh,
Mari.
yes. Thank you very much for every time. And thank you very much for pretty informative information. And in Japan, more than 100,000 people had a vaccination. and only 37 had been reported as anaphylactic reaction. Only 2 is very severe, but they survive with the injection. And also the one death after 4 days of she had a shot, but no further death had been reported. So now we are getting more people has vaccination. Thank you very much.
Yes, thank you, Dr. KK. All right, what's happening in Malaysia is at the moment we're only using the Pfizer. The progress is actually slow but steady. So far, the only complaints we hear about is the sore arm and all that. I feel maybe it's not being fully reported because I think the government does not want to panic the public, because there are many people who are on a wait and see attitude regarding the vaccine. So I believe that most probably what the government is doing is they're not highlighting the serious side effects. The only thing we hear about is just a sore arm, and that's about it. But otherwise, I think things are going on quite well. Thank you.
Anybody else who is there? Otherwise, Dr. Akhtar, who is, I don't know. I'll request Dr. Chong to sum up.
Good morning, Dr. KK and the listener. Good morning from South Africa, from Durban, from South African Medical Association. So far, we are using Johnson & Johnson single-dose vaccine. We have given 200,000 vaccination. That's only for health workers, and we haven't started to give other community or older age people. There's a very few side effects reported, and there's a good follow-up for the side effect, minor side effects reported through the email system. And we had one severe reaction. This was a lady admitted and recovered very well, discharged next day. And we are getting 20 million vaccine from Pfizer. So that will be maybe next month. Otherwise, program is going slowly.
So Dr. Akhtar, we will be interested in the Johnson & Johnson data, because logically Johnson & Johnson is also a vector virus. It is also a fixed dose FDC drug, because there are 2 viruses involved. But the difference is this is human adeno and that is chimpanzee adeno, but both of them are adeno. So we will be interested in getting the data of side effects. Will it behave like similar to Oxford or not? So we will be interested in knowing the data on a regular basis.
Yes, we will provide as soon as we get more information on the side effects.
Dr. Chong.
Thank you, President, and always a pleasure to have all of us here together on a Saturday morning and to learn about the various fallout from the vaccination programs across the world, across the globe, and the most fascinating insight into the various mechanisms, immunology mechanisms, plus the correlation with clinical signs and symptoms, plus the correlation with blood investigations. I always find this most informative and very, very useful. Thank you, President, and thank you all for attending the session, and we look forward to next week's session.
Okay, thank you.
Thank you.
Thank you, Dr. KK, Dr. Chong.
Very much.
Thank you.
Bye.
Bye.
Bye.